Just to talk a little bit about the adverse events that are more commonly seen with these ALK inhibitors as a class, just wanted to mention that we do more commonly see GI toxicities, which include nausea, vomiting, and diarrhea with ALK inhibitors in general, as well as liver function abnormalities. These were more commonly seen with the earlier generation ALK tyrosine kinase inhibitors, the crizotinib and the ceritinib, compared to the later generation ALK inhibitors, but just important to keep these toxicities in mind. Anemia and myalgias are also seen in patients treated with ALK inhibitors, more common with the alectinib compared to some of the other ALK inhibitors. And then, of course, visual impairment is also an adverse event that we think about with these ALK inhibitors. This was more commonly seen with crizotinib. Thankfully, this was usually transient, and it's less common with the later generation ALK inhibitors, but just to be aware of these more common adverse events with the ALK inhibitors. So as I mentioned, although we're really excited about the efficacy of these drugs for our patients with ALK rearrangements, despite the efficacy, we know that acquired resistance, unfortunately, is considered to be inevitable. So these drugs will stop working at some point. And when they stop working, we oftentimes see both on-target and off-target pathways that seem to develop at the time of resistance. So on-target really refers to alterations within the target kinase, and off-target alterations include kind of new bypass pathways that are formed or histologic transformation. I'll mention that for ALK, histologic transformation is not as common as in EGFR, for example, but it is something that we do see from time to time. The most common ALK resistance mutations in patients who are treated frontline with alectinib are the G1202R resistance mutation, which is seen in 25 to 30% of cases, and then the I1171X alteration seen in 10 to 15%. So these are on-target alterations that can form in patients who are treated with alectinib frontline. The good news is that when we see these resistance alterations, we know that lorlatinib can actually target these alterations. So when we have patients who progress on frontline alectinib, we do a repeat biopsy, we see one of these ALK resistance mutations, we can then go ahead and treat with another ALK inhibitor, usually lorlatinib, to try to overcome this resistance. We know that when we're treating patients with the third generation ALK inhibitor lorlatinib frontline, that we can see these more complex resistance mechanisms. And so sometimes we'll see compound ALK mutations, more of these bypass and downstream signaling pathways. So that's just important to keep in mind. So many of us are still using alectinib frontline, but we do now have approvals for both brigatinib and lorlatinib frontline. And so if those are used, it's just it's just important to point out that we are seeing, sort of other kinds of resistance mechanisms that are popping up. We know that the specific ALK fusion variant may influence the development of on-target resistance. So I think it's really interesting work that has recently discovered that maybe the specific variant will be able to predict what the resistance mechanism will be that develops. And then I just finally wanted to state that repeat tissue biopsy at the time of disease resistance is commonly recommended. And it's really to be able to figure out what is happening at the time that the ALK inhibitors has stopped working. Is this something that we can target with another ALK inhibitor? Is this something that we can target with some other drug? And so I think it is important to try whenever possible to perform a repeat tissue biopsy at the time of disease resistance.